I have not started.
Yeah, I've just realized that I never started recording. So when it comes to vaginal examination, it's a sterile procedure. And apart from that, you do it in a pregnant woman. And there are certain parameters that you need to take note or mention based in a pregnant woman. So it's a sterile procedure, and for you to do this particular procedure, you need the sterile gloves as well. You need to do an invasive hand wash where you do that hand wash for sterile procedures all the way up to the elbows. And the first thing that you need to start with is, of course, vulvar swabbing before you move on to the actual vaginal examination. So as usual, you read the scenario to say Miss Grace was brought in or has come to your facility with active abdominal pain, and the woman is active in labor per se. And from there, as the physician on duty, I've been tasked to do vaginal examination so as to monitor the progress of labor. So immediately you read the scenario, you are as well going to sanitize or wash your hands, and you are going to do an invasive hand wash. But the first thing, you just wash your hands and you go to the patient or the client to gain consent, to say, Miss X, after gaining consent, this is good evening, Miss X or Miss Grace. I'm a physician or student number X or 52. I've been assigned to perform vaginal examination so that you can monitor the progress of labor and draw out any abnormalities. Can I go ahead? Anything I can do for you around here before I proceed? Thank you. I'll be back to do the procedure. Then after you just gain the consent, you wash your hands, then you don in the gloves and position the patient nicely. But during OSC, you find that the dummy is already positioned. So you just expose the dummy and say, I've screened to ensure privacy. And then you are going to prop up the knees of the patient and position them in a dorsal recumbent position, where you just lift the knees, like when you're sleeping in supine position and you just lift the knees of the client. So after doing that, just say, Miss X, I'll be back. Don't worry, I've screened to ensure privacy. Then you are going to remove those examination gloves and then do the invasive hand wash. But during OSC exam, you won't do the whole process of the invasive hand wash because it takes you close to 5 to 10 minutes to complete it. But during OSC, because it is timed, you'll be allowed to use sanitizer and show how to do the invasive hand wash all the way to the elbows. You do just the last part. Then from there, you're going to don in the sterile gloves. So you don in the sterile gloves because it is a sterile procedure, and you don in the sterile gloves without contaminating as you don them in. So after you don in the sterile gloves, the next thing that you are going to do is that you are going to start by performing what is known as vulvar swabbing. So you get a swab. You get a swab which will be on your station like that. So you find that your station will be prepared and there will be some swabs. So you get the first swab and you pass it on to the working hand, and you clean the vulva by starting with the furthest labia majora. So in this case, you wipe the left labia majora, you discard this gauze and you pick another gauze, wipe the right labia majora and discard. And then from there, you move on to the left labia minoras, which are the minor lips, wipe and discard. Then you move on to the right labia minora, you discard. Then you get the fifth swab and wipe the introitus, which is the middle of the vulva. At this point, it means you have done vulva swabbing, and now you are ready to start the actual procedure of vaginal examination. So in certain scenarios, again, they may tell you to say vulva swabbing has been done. It means that immediately after you scrub all the way to the elbows and you don in sterile gloves, you straight move in to start the vaginal examination. But if they have told you, if they have not mentioned to say vulva swabbing has been done, meaning you need to start from vulva swabbing, then you go to vaginal examination. So at this point, I've done vulvar swabbing, and the first thing you're going to start with is an inspection. So you're going to say on inspection, I can not see any presence of genital warts or sores, and this is normal. And then immediately you're going to use the two fingers, which are known as examination fingers in this case, and you are going to go into the vagina in a downward motion upward structure. So you go in down, then once you are in, you move your hand up like that. So once you go inside, the first thing you're going to do is feel for the warmth of the vagina. The normal in a pregnant woman is that it should just be warm, moist, and distensible. So when you go in, you need to feel for the warmth. If it is warm, that is normal. The next thing, if it is moist, that is normal. And if it is distensible, that is also normal. It feels like it's stretching because of the rugae of the vagina. It needs to be distensible. So once you feel that, then that is normal. Before I move to the next step, if you go in, you find that the vulva or the vagina is very hot. It indicates that this particular woman has an infection if it is very hot, or there is cephalopelvic disproportion amongst other causes. So you find that in cephalopelvic disproportion, there is mainly delayment in delivering in this woman because the baby can't come out, and hence you find that it is the vulva or the vagina is very hot. But the normal, I've said, once you go in, you're just going to say the vagina feels warm, moist, and it is distensible. Then once you feel for that, the next thing that you're going to do is you're going to move deeper and feel for the cervix. So once you reach the cervix, you're going to mention to say the cervix feels thick, and what you're feeling for on the cervix is whether the cervix is thick or thin. But the normal is that the cervix should be thin because a thick cervix delays labor. So the normal, the good sign should be that the cervix should be very thin. So once you feel for the thickness or thin of the cervix, you mention whether it's thin or thick based on what you find. Then you are going to now feel for the os, the cervical os. So now, when you reach the cervix and you're feeling for the cervical os, it literally feels like the tip of the nose, like you're pressing on your nose. Then you know that you have reached the cervix. So once you reach the cervical os, you're going to determine the dilatations. That's the first thing you take note. So if you reach the cervix and only the tip of your one finger, so you're using the fingers, and only the tip of your finger can feel or can be accommodated in the cervical os, it means that the dilatations are at 2%. Now, once you go, if you go in and two fingers are able to be accommodated like that, it means that the dilatations are at 4%. Then you're going to open the two fingers like that. If you feel like there's a third finger that can be accommodated in between to make 3 fingers, it means that the dilatations are at 60%. If you feel like, again, when you open them, like 2 fingers can again go inside like that, it means that the dilatations are around 8 centimeters. But if you open wide your fingers and you can't even hit the walls of the cervix, it means that effacement has fully taken place and this woman is at full dilatation, which is around 10 centimeters. At that particular stage, it means that this woman can start pushing. So you find that the hands in obstetric that determines the dilatations, it is these 2 eyes. You create the senses of these feelings of the fingers, and then they will guide you in terms of the dilatation. So I said, once you reach the cervix, you need to feel for the cervical os and determine the dilatation. Is it at 2 centimeters, 4 centimeters, 6 centimeters, or 18 centimeters? So once you determine the cervical dilatation, the next thing you're going to feel for while you're inside is are the membranes. Are the membranes still intact, or have the membranes ruptured? So if the membranes are still intact, you wait until the membranes rupture. If the membranes have ruptured, well and good, you are going to now feel for the presenting part. So if the membranes have ruptured, you are going to feel for the presenting part. And in a child, because the normal is that the child is supposed to be in longitudinal position, you should be able to feel the occipital bone of the fetal head. So you feel for the presenting part. If you are able to feel the occipital bone of the fetal head, you're going to say the presenting part is the occiput, which is normal. But you need to take note in an actual woman whether it is this woman, this baby is in an abnormal position or in any other position, like whatever is presenting. Maybe you find that it's the buttocks or which is breech presentation. But the normal is that you should be able to feel for the occipital. That should be the normal. So after you feel for the presenting part, you are now going to move on and feel for the cord presentation. Are you able to feel the cord where the head is? And that is cord prolapse. That is not normal. So if you're able to feel for the cord in front of the head, you need to feel whether it is pulsating. If it's not pulsating, meaning this baby will go into asphyxia immediately. So you need to take this woman immediately for a cesarean section. But if it's pulsating well and good, you can just maneuver it and control the process. But if you feel for the presenting part, there's no cord in front, that is well and good. You will just continue with other examinations. So after you feel for the presenting part, the next thing that you should feel for at the sagittal is the sagittal suture. So remember, on the examination of a newborn, we said there is a sagittal suture here, which you need to feel for, and that is normal. And then you need to feel for the anterior and the posterior fontanelle. So when you go in and the sagittal suture, you can feel it closer to the left side of the vagina, or inside the vagina, close to the left side. It means that the baby is in left occipital anterior. But if you're able to feel the sagittal suture closer to the right side of the vagina, it means that the baby is in right occipital anterior, meaning the baby is descending in the right side position, or the left if you are able to feel the sagittal suture closer to the left of the vagina. Then from there, after you feel for the presenting part and the sagittal suture as well as the fontanelle, the next thing that you need to feel for are the ischial spines. So the ischial spines control labor, and as you are feeling for the ischial spines, the normal is that the ischial spines should be blunt and not prominent. If the ischial spines are prominent, it means that they are more like pointed inwards, and they are going to prevent the delivery of this baby. So as you feel them in the normal, you're going to say, okay, the ischial spines are blunt and this is normal. But if the ischial spines are prominent, it means that these are going to delay labor. Then apart from that, once you are done with those points, it means that you are done examining the vagina, and then you are going to take out the 2 fingers out. Once you take them out, do not rush to remove the gloves. You need to observe the discharge, or the mucus discharge that you have come out with. If you find that the mucus discharge is a blood stained, that is presence of Shaw. Remember, there is a mucus plug or operculum which closes the cervical os. Immediately this woman becomes pregnant, and this is what prevents labor to take place before 9 months. But immediately the true contractions start, the operculum discharges, and then when your fingers are out, you find that there will be a mucus blood stained, and this may indicate that this particular the operculum is out, and we call that as the Shaw, presence of Shaw, and that is normal. But when you take your 2 fingers out and it is meconium stained, meaning the mucus has feces for the fetus, it may indicate that there is a fetal distress, and in normal cases, you are going to rush this woman to C-section, or you are going to augment labor so that the baby is out as soon as possible. So if it is meconium stained, it means that the baby, there's fetal distress. But if it is blood stained, and the mucus is blood stained, it just indicates presence of show. It means that the mucus plug has discharged because the cervix is effacement, which is expanding until it opens wider so that the baby can easily come out. So once you take the 2 fingers out, you just mention that, and then at this point you are done examining the vagina, and you are going to remove the sterile gloves. After removing the sterile gloves, you're going to get the sanitizer, sanitize or wash your hands, and then you say, I'll document and report the findings. So when examining the vagina, this is how you do vaginal examination, unless there's a question.